Hi, this is Philip Ador, founder of NCLEX RN 45-Day Challenge. In this video, I'm going to be talking about cholecystectomy. Acute cholecystitis is an inflammation of the gallbladder, and it's usually because of the obstructions of the cystic duct by gallstones. Acute cholecystitis is the most common complications of cholelithiasis, which is formations of the gallstones in the gallbladder. Just to be clear, cholelithiasis is a formation of stones in the gallbladder which can lead to a few complications, one of which is acute cholecystitis. The other terminology, cholelithiasis, is formations of gallstones in the common bile duct. In this video, we will mainly focus on the acute cholecystitis. But really, we will also talk about every other complications, and hopefully we can get our head around it together. Let's look at the normal anatomy of the upper GIT partly. So here is the gallbladder. Now, the gallbladder is an organ that stores what's called bile. And bile is a mixture of cholesterol and other pigments. The bile is important in digesting fatty foods. The bile is actually produced by the liver, and gallbladder just stores the excess bile. So back to anatomy. Here is the gallbladder, the body of the neck, and the fundus of the gallbladder. This is the cystic duct coming out from the gallbladder and connects to the common hepatic ducts, which arises from the liver. The joining of the cystic duct and common hepatic ducts forms the common bile duct, which runs all the way down and joins with the pancreatic duct from the pancreas. Before moving to the pancreas, the stomach actually continues into this morning test. Down here, transporting the half-digested food content. The first part of the small intestine is the duodenum. Then the duodenum goes into the jejunum, which is the second part. And here is the pancreatic duct I was talking about. And here is a part of the pancreas, and essentially the gallbladder will contract and release the bile. The liver will release bile, which will go down and end up in the common bile duct. The common bile duct runs all the way down and joins with the pancreatic duct from the pancreas. The newly formed duct will release the bile, the enzymes from the pancreas into the duodenum through the ampulla or vater to help to digest the food. In acute cholecystitis, our gallstones, which was formed in the gallbladder, get stuck in the cystic duct. Now, a lot of us actually has gallstones in our gallbladders, but they don't cause any problems, and we are asymptomatic. Sometimes people get unlucky and the gallstones get stuck either temporarily or sometime. There are many types of gallstones, but we won't talk about that here. Just think of gallstones as a mixture of cholesterols and other pigments with bile. So when the gallstones get stuck in the cystic duct, the gallbladder will try to contract and push it out without any success. And this obstruction results in the inflammations to the gallbladder, and this is acute cholecystitis, called biliary colic and cholangitis. But these three conditions do differ. We won't talk about them now, but they differ in the pain, having fever, increased white cell count, and finally jaundice, which is a yellowing of the skin. So what are actually these conditions? Biliary colic is where there are only temporary obstructions of the gallstones at the neck of the gallbladder, so we can go in and out. Acute cholecystitis, as we mentioned, is a gallstones stuck at the cystic duct causing inflammations of the gallbladder. And cholangitis is a complications of the gallstones where infections develops in the common bile duct, and this is a life-threatening. So, the signs and symptoms of the acute cholecystitis specifically are the fever, nausea, vomiting, right upper quadrant pain, pain which may radiate to the right side of the back. On examinations, there is a positive Murphy's sign. Murphy's sign is where a hand is placed at the midpoint inferior border of the liver. The patient is then asked to take a deep breath in, and the diagram below is during the inspirations and with our hand being placed where it is. It will irritate the gallbladder as the diaphragm pushes the gallbladder down, and this will trigger the pain. Patient becomes throttled and stop breathing in. So, going back to the small table we made. The difference is in three conditions: biliary colic, acute cholecystitis, and cholangitis. Biliary colic only presents with right upper quadrant pain typically. Acute cholecystitis has a right upper quadrant pain with fever and raised white cell count. And finally, cholangitis presents with right upper quadrant pain and fever, increased white cell count, and jaundice or yellowing of the skin. These three findings makes up what's called the Charcos triad. Complications of cholecystitis is a tumor of the gallbladder, chronic cholecystitis, mucocele, where mucus is accredited into the gallbladder, emphysema, which a pus in the gallbladder. Thanks to the infections by the bacteria, there is Merit-C syndromes, and Merit-C syndromes is basically when the gallstones in the cystic duct are actually impacts or obstructs the hepatic ducts. An obstruction of the hepatic duct means that the bile being produced by the liver will go backwards, will backflow and cause what's known as the obstructive jaundice. Other complications include perforations of the gallbladder, gallbladder duodenal fistula, which allows the large gallstones to pass through causing gallstones ileus at the terminal ileum. Gallstones can trigger cholangitis from choledocholelithiasis or cholelithiasis when it obstructs the common bile duct. Gallstones can cause pancreatitis if it obstructs the passage of the contents from the pancreas into the duodenum. Finally, obstructions of the common bile duct or above can cause backflow of bile to the liver. On this side note, there's something called as Courvoisier's law. And the Courvoisier's law essentially says that the presence of the enlarged gallbladder with jaundice is unlikely are due to gallstones rather than the carcinoma of the head of the pancreas. Investigations that can be performed with the person suspected of the biliary 3 problems include full blood count, which may show raised white cell count, amylase lipase to check for pancreatitis, CRP, UIC, LFT. And LFTs are important because there will be abnormal LFTs with the problem that occurs in the biliary tree system. Ultrasound is a diagnostic and can detect gallstones, and it is used to elicit Murphy's sign too. Abdominal x-rays can only pick up 10% of the gallstones. Another imaging technique is the high discount, which is the contrast scan that lights up the biliary tree. If the biliary tree doesn't light up fully, there can be obstructions. The management of the acute cholecystitis is a surgery. Again, people can have gallstones normally, and if they are asymptomatic, there is no reason to remove the gallbladder unless they have the risk factors for future complications. Surgery is done for symptomatic people or people with recurrent gallstones disease, and the management of acute cholecystitis before the surgery is nil by mouth, fluids and IV antibiotics, pain relief with analgesia. Surgery can be done laparoscopically or open. Laparoscopic cholecystectomy is done over cholecystectomy. In laparoscopic cholecystectomy, there are a few ports or holes in the abdomen that can be made. These include the surgeon point, under the sieve externum, the Hessian camera point, assistant point, and the accessory point. Let us look inside the abdomen from the inferior view. The abdominal cavity is pumped with air, carbon dioxide, and this makes the surgeon's work easier, as it creates space. So here is the liver and gallbladder. Here is the laparoscopic light that views the area. From the Hessian camera point and the two assistant ports, as examples of the low things are assessed in the area. Firstly, what happens is that they want to expose the gallbladder because the gallbladder and the digestive organs are surrounded by the visceral peritoneum. When the gallbladder is exposed, the cystic artery is clipped and the cystic duct is also clipped. And then the incisions are made in between the clips. This is in order to prevent the spillage of contents within the bile ducts. Once the incisions are made, the gallbladders can safely be removed. The cystic duct is clipped, and so it doesn't bleed out, and the cystic duct, remember, when also clipped, and so it doesn't spill anything as well. When the gallbladder is removed, Everything is put under the visceral peritoneum once again. It's stitched up and the surgery is done. However, sometimes an open cholecystectomy is needed. This is specifically if there are complications from the gallstones or complications during the laparoscopic surgery. In the first place, an open cholecystectomy is quicker, but it is much more invasive.